Welcome to the deep dive. Today, we are taking a really comprehensive, high-yield shortcut through the essential knowledge base of clinical hematology.
And we're pulling our focus directly from the second edition excerpts of a fantastic resource, Wintrobe's Atlas of Clinical Hematology.
Our mission here seems, well, pretty crucial. It's about synthesizing that foundational knowledge, the visual stuff.
What you literally see down the microscope.
Exactly. And blending that with the just explosive growth in modern diagnostic technology.
Right. And hematology is pretty unique in that way. That classic morphology, it still grounds every single diagnostic decision, even while all the genetic testing is just accelerating at an incredible pace.
For you, the learner, that really is the key, isn't it? Integrating those two worlds.
It is. The field has changed so dramatically, even just since the first edition of the Atlas. We're talking about huge advances in molecular and immunophenotypic techniques.
So this is not just a review of definitions. We're really focusing on how these different diagnostic layers stack up and inform each other.
Right. We've broken this deep dive into three main pillars. First, the bedrock, foundational lab work, and microscopy.
Okay.
Second, we'll get into the advanced techniques, flow cytometry, mIHC, that kind of thing.
And finally put it all together.
Yep. Apply everything to the clinical classification of anemias, hemostasis, and the major blood cancers.
Okay, let's unpack this and start with what we're calling the visual start, the peripheral blood smear.
Every patient journey really begins with a complete blood count, a CBC. That's from an automated analyzer.
Right, the machine spits out the numbers.
Exactly. But when that machine flags an abnormal parameter, say a high RDW or an anemia it can't explain, we have to go back to the smear. That slide is our first critical layer of information.
And the prep itself is highly standardized.
Yeah.
We're talking Romanowski-based staining methods.
Usually right or Jim sustain. And the chemistry here is just fundamental to everything we see. You've got two dye components.
First is eosin. That's the acidic dye, right?
It is. And it binds to alkaline structures. Think hemoglobin or the granules inside eosinophils. It gives them that characteristic red or orange color.
And the other half is methylene blue.
The basic dye. It binds to acidic things, mostly nucleic acid, so DNA and RNA and the granules in basophils. That's what gives you all those different shades of blue and purple.
And what's so fascinating here, something the Atlas points out, is that the staining process can offer you a clue before you even look down the scope.
A macroscopic clue, yeah. It's a great little pearl.
So what are we looking for?
You just hold the slide up to the light. If you see this really excessive bluish or purplish discoloration across the whole smear, that can be a tip-off.
A tip-off for what?
It often happens when there are just extremely high levels of plasma proteins, like the monoclonal immunoglobulins you see in multiple myeloma. They non-specifically soak up that basic dye.
Wow. That's an amazing nugget of information. Using the naked eye for a diagnosis that we now associate with, advanced genetic testing.
It all connects.
So after checking the general color, the systematic slide exam begins. And the Atlas really stresses starting at low power, by 10 by 20. Why start low?
You need that bird's eye view first. You're checking the overall quality, looking for staining artifacts, making sure the cells are spread evenly.
And you're looking for that sweet spot on the slide.
Critically, yes. You're hunting for the optimal thin area. You want the red blood cells, the RBCs, to be in a single layer. They should be close, but not overlapping, and you need to see that normal central pallor.
Because if you're in an area that's too thick,
you'll misread everything. You might misclassify spherocytes, or you could totally miss crucial fragments. It all starts with finding the right real estate on the slide.
Okay, so once we're in that optimal area, the real assessment of the RBCs begins.
Right.
We classify size first.
Right, and practically you compare them to the nucleus of a normal lymphocyte. If they're a lot smaller, they're microcytic. Bigger, macrocytic.
And then we look at variation.
Yep.
Anisocytosis.
Is the variation in size. That's what the RDW, the red cell distribution width, is measuring objectively.
And poikilocytosis.
That's a variation in shape. And this requires your eye. You have to specifically identify what you're seeing. Are they target cells? Teardrops? Elliptocytes? Or, and this is a big one, are they schistocytes? Those little fragments that scream microangiopathic hemolytic anemia.
You also have to spot inclusions. Things like Howell-Jolly bodies.
Which are nuclear remnants you see after a splenectomy. or Pappenheimer bodies, which are little iron-containing granules. This is all just classic high-yield stuff.
And we move to the white blood cells, the WBCs.
And the manual differential counting 100 to 1,000 cells by hand, it's still mandatory. You're checking for maturity, for abnormal granulation, and for the presence of immature leukocytes.
Or nucleated RBCs in the peripheral circulation.
Which is a huge red flag. It's a sign of severe bone marrow stress, or that something is replacing the marrow, a process called myeloproliferative.
So moving from the periphery into the marrow itself, the bone marrow evaluation.
And you need two complementary pieces of information here, the aspirate smear and the core biopsy.
What's the specific role of each one?
The aspirate is liquid. It gives you just superb cytologic detail, the fine grain of the cells. And that's essential for things like flow cytometry and molecular analysis. You have to see those little gray specks, the marrow particles, to know you have a good sample.
But what happens if the patient has a dry tap? You can't aspirate any liquid marrow.
It's a classic clinical frustration. It happens when there's a lot of fibrosis or just really dense cellularity.
So then what?
You have to rely on less ideal touch preparations, basically blotting the biopsy core onto a slide. And the diagnosis then hinges even more heavily on the core biopsy itself.
Because the core is the architectural map.
Precisely. It tells you the overall cellularity, the ratio of hematopoietic cells to fat, and it lets you assess the bone structure and look for focal lesions like, say, a tumor infiltrate.
And to wrap up morphology, you're looking at megakaryocytes.
The giant platelet-producing cells, best seen at low power. But for the detailed maturation of the other cell lines, you really need to be at a higher magnification.
Okay, so now we connect that visual foundation to modern precision. Let's talk about multiparameter flow cytometry, MFC.
Right, and this is a huge shift. We're moving from looking at fixed dead cells on a slide to assessing live cells in a liquid suspension.
And the flow cytometer itself is firing lasers at individual cells as they stream by. It's measuring how that light scatters.
That's right. Forward scatter, or FSC, tells you about the cell's relative size, and side scatter, SSCA, that tells you about its cytoplasmic granularity, its internal complexity.
The core principle here is identifying proteins, right?
It is. What's on the cell surface or inside the cytoplasm, you tag those proteins with fluorescently labeled antibodies.
And there's a crucial practical limitation here.
Yes, you need viable cells, live cells. If the cells are dead, the antibodies just stick everywhere non-specifically, and you get a ton of background noise that makes interpretation impossible.
Now, the atlas suggests that for most clinical purposes, 4 to 8 colors are enough, even though the tech can do more. Why not use, 20 colors?
It's a matter of diminishing analytical returns. The real clinical power of flow comes from looking at two-dimensional scattergrams and a technique called gating.
Gating?
Right. You draw a gate around a population of cells on one plot to look at them on another. Too many colors just makes the plots overly complex and the analysis a nightmare. A focused panel is much more effective.
Let's talk about that essential gating strategy. How do we start to separate the WBC subpopulations?
The primary gate is always CD45 versus side scatter. Lymphocytes are bright CD45 and have low side scatter. Blasts, the immature cells, are typically dim CD45 and also have low side scatter.
And where are the plasma cells?
That's a diagnostic aha moment. They are often CD45 negative or very dim with intermediate side scatter, so that initial gating lets you just home in on the specific population you're suspicious of.
That capability has huge implications. For instance, MFC is the gold standard for diagnosing chronic lymphocytic leukemia.
Absolutely. And if we're looking at, say, a B-cell non-Hodgkin lymphoma, the whole diagnosis relies on identifying monotypism.
Meaning what, exactly?
Normal reactive B cells are polytypic. They express a mix of kappa and lambda light chains on their surface. A cancerous population is monotypic. It expresses only kappa or only lambda. That's the definition of B-cell clonality. It's the difference between a reactive lymph node and a lymphoma.
We also use it for very specialized things, like diagnosing PNH.
Paroxysmal nocturnal hemoglobinuria, yes, by looking for GPI anchor deficiency using markers like FEL-AER and CD59.
And in myeloma, or plasma cell neoplasms.
We find the abnormal clone by its aberrant expression. For example, normal plasma cells should express CD19, the malignant myeloma cells. They often lose CD19 and pick up strange markers, like CD56.
So you gate on that bright CD38 dim CD45 population and then look for those weird patterns.
That's exactly how it's done.
Okay, moving from liquid analysis back to the slide. We have tools that give us spatial context, like multiplex immunohistochemistry or mIHC,
This is invaluable. It lets us run multiple stains on a single tissue sample on one slide.
and see them at the same time.
At the same time, on the same cell. A great example is in plasma cell disorders. You can stain for CD138 to identify all the plasma cells, and then stain for cyclin D1 in the nucleus.
Why cyclin D1?
Because a strong diffuse nuclear cyclin D1 signal is highly suggestive of the T1114 translocation. This lets you rapidly distinguish it from, say, hyperdiploidy, which gives a weak or negative signal. It's a beautiful integration.
And speaking of morphology driving molecular workups, amyloidosis.
The diagnosis of amyloid has to start with morphology. You need to see those dark red deposits on a Congo red stain.
And then confirm it with polarized light.
Right. You have to see that pathognomonic apple green birefringence under polarized light. That confirms you have amyloid. The misfolded protein is there.
So if the diagnosis is visual, what's the role for something advanced like mass spectrometry?
Mass spec is crucial, but not for diagnosis. It's for identifying the specific type of protein that's being deposited. Is it Ig light chains, which is AL amyloidosis, or something else? The protein type determines the treatment, but it doesn't make the initial diagnosis.
And finally, we have the molecular studies themselves. PCR, RT-PCR, FESHOR.
These are the workhorses. PCR for B, or T-cell clonality, RT-PCR for monitoring the BCR-ABL1 fusion in CML, and FESH for spotting key translocations fast, like T1517 in acute promyelocytic leukemia, where you need to start treatment immediately.
Okay, let's apply these tools, starting with anemia. The classification usually begins with the MCV.
The mean corpuscular volume, yes. If the MCV is less than 80, you have a microcytic anemia.
And the two most common causes worldwide are iron deficiency and the thalassemias.
Right. And what's important to remember about the progression of iron deficiency is that it doesn't start out microcytic.
It's a journey.
It is. First, you lose your iron stores, so your ferritin drops, then becomes a normocytic anemia. Only in the later stages do you get that classic microcytic hypochromic picture.
So the full diagnosis requires iron studies.
Low serum iron, high total iron binding capacity, and a ferritin level often below 20. And the smear backs this up. You'll see microcytes, hypochromia, and those classic elongated pencil cells.
What's another cause of microcytosis?
Sideroblastic anemia. This is characterized by ring sideroblasts in the marrow erythroid precursors, where iron granules are literally encircling the nucleus. A classic acquired cause is lead poisoning.
Okay, moving to the other end of the spectrum. Macrocytic anemias, MCV over 100.
The most important subgroup here is megaloblastic anemia from B12 or folate deficiency. And the smear gives you a massive diagnostic giveaway.
The oval macrocytes are one thing, but there's something else.
The absolute morphologic clue you have to recognize is the hypersegmented neutrophil.
What's the definition for that?
If you find more than 5% of them have 5 or more lobes, or if you even see 1 or 2 cells with 6 or more lobes, that finding should immediately make you think of a vitamin deficiency.
And then there's the big middle category, normocytic anemias.
Anemia of chronic disease, or ACD, is the prototype, usually normocytic, normochromic, and pretty mild. Though it's worth noting about a third of cases can become mildly microcytic over time.
Chronic renal disease is another big one.
Absolutely, tied directly to not making enough erythropoietin. And you can sometimes see fragmented cells like Burr cells because of the uremic effects on the blood.
Let's shift gears to hemostasis. Primary hemostasis is the platelet plug.
Right. Adhesion, activation, aggregation. And that key aggregation step relies on fibrinogen binding to the GPI-A3 complex on the activated platelets.
And secondary hemostasis is the coagulation cascade, forming the stable fibrin clot.
Exactly. When problems come up, they can be inherited, though things like gray platelet syndrome are quite rare.
But acquired issues are very common, things like warfarin.
A vitamin K antagonist affecting factors 2, 7, 9, and NX, and of course the DOACs, the direct oral anticoagulants, which directly block thrombin or factor X.
We have to touch on the major thrombotic conditions, heparin-induced thrombocytopenia, HIT.
It's a deeply paradoxical syndrome. You have IgG antibodies that target these PF4 heparin complexes. This causes rapid clearance of platelets.
So thrombocytopenia, a low platelet count.
Right. But at the same time, this interaction triggers massive platelet activation and aggregation, leading to severe, often life-threatening thrombosis, both arterial and venous.
And then there's antiphospholipid syndrome, APS.
Which requires both the clinical event a thrombosis or a specific pregnancy complication, and the documented presence of an antiphospholipid antibody.
Okay, let's get into the neoplasms. This is where all this integration really shines. Let's start with a critical comparison. MDS versus MPN.
Myelodysplastic syndromes versus myeloproliferative neoplasms. The fundamental difference is efficiency.
MPNs are effective hematopoiesis.
Exactly. So you get increased cell counts, often with an enlarged spleen, and they are defined by very clear driver mutations. JK2, CLR, MPL, or the big one, BCR, ABL1.
Whereas MDS is the opposite. It's ineffective hematopoiesis.
Right. So you get low counts in the periphery, the cytopenias, even though the marrow is usually packed with cells. And this is why morphology is still the gatekeeper for MDS. The diagnosis depends on identifying morphologic dysplasia abnormal-looking cells in at least 2 lineages.
The most famous MPN has to be chronic myeloid leukemia, CML.
Defined by the Philadelphia chromosome, that T922 translocation, creating the BCR-ABL1 fusion protein, which is a constantly active tyrosine kinase.
And diagnosis is all about finding that fusion.
Right, usually with FIDH or PCR. And CML is such a success story because of tyrosine kinase inhibitors, TKIs. So monitoring is now entirely molecular, using quantitative RT-PCR to track the level of that BCR-ABL1 transcript.
Okay, shifting to leukocytes. Most neutrophilia is just reactive.
Usually a bacterial infection, right? But lymphocytosis, that requires very careful differentiation.
Reactive versus neoplastic.
Exactly. A reactive lymphocytosis, like in a viral infection, is polyclonal. It's a heterogeneous mix of cells. A neoplastic one is clonal and monotonous. The cells all look the same.
Finally, let's talk about plasma cell neoplasms, PCNs. This is a whole spectrum of disease,
It starts with MGUS, monoclonal gammopathy of undetermined significance.
which is defined by a small M spike, less than 10% plasma cells in the marrow.
And crucially, no evidence of end organ damage,
The transition to malignancy is multiple myelomas.
where you need at least 10% plasma cells plus one of the classic CRAB features, hypercalcemia, renal dysfunction, anemia, or bone lesions.
But the criteria have evolved, haven't they?
They have. The newer IMWG criteria added specific high-risk biomarkers that define myeloma even without CRAB features. Things like having over 60% plasma cells in the marrow, or a free light chain ratio over 100. It shows how molecular markers are now defining malignancy itself.
And we finish with AL amyloidosis, which we mentioned earlier, the deposition of Ig light chains.
As those eye-pleated sheets, yes, it's a systemic disease, and our ability to rapidly identify that clonal plasma cell population with flow and then confirm the protein type with mass spec, it just ensures patients get the right diagnosis and therapy quickly.
It's so clear that successful hematologic diagnosis today is a synthesis. It's not one thing.
Not at all. Morphology gives you the foundational visual evidence, the dysplasia, the fragments, the architecture, and then the molecular and flow techniques give you the precise classification and prognostic data.
Morphology is still the essential framework. It tells you where to aim those advanced tools.
Absolutely. If you miss the hypersegmented neutrophil on the smear, you might miss the diagnosis entirely, no matter how good your lab's B12 assay is.
Which brings us perfectly to our final thought, a synthesis exercise that pulls all of this together.
Okay, imagine this scenario. A new patient presents, and their CBC report shows 2 critical findings: an MCV of 75 FL-SO microcytic and an RDW of 18.5%, which is very high.
So small cells, but a big variation in their size.
Exactly. And the person examining the peripheral smear notes, microcytes, hypochromia, and numerous elongated pale RBCs, the classic pencil cells.
So based solely on those morphologic and CBC findings we've discussed, the pencil cells, low MCV, high RDW, what is the most likely provisional diagnosis? And what single lab test is the gold standard for confirming it and telling it apart from its biggest mimic, thalassemia trait?
Just think about the progression of the most common anemia in the world and how we measure its stores.
The provisional diagnosis has to be iron deficiency anemia. And the single most important confirming test is the serum ferritin level.
That's it. A low ferritin confirms that the iron stores are exhausted. And that's what provides the necessary distinction from thalassemia trait, where the ferritin levels would typically be normal or even high.
That's synthesis. Seeing the morphology, knowing the kinetics, and ordering the definitive test.
That's what modern hematology is all about.
A perfect place to end this deep dive. Thank you for joining us.